Okay, hi all, thank you for listening. As Joanna just said, I am a AHP ambassador that is seconded to Health Education England to help promote the uptake of the AHP R's roles within primary care. I'd like to thank Paula and Rob, who is on the call, who have helped with this presentation. Rob is going to share his screen. You will need your phones because this is a Mentimeter activity. All right, and using it's very easy. You just need to go onto the website and you'll be able to answer everything from there. Okay, so as Rob has clearly shared his screen now, we'll get going. Okay, so I've been invited to discuss all the R's roles with you. And we debated long and hard how to do it. Next slide, please, Rob. Okay, so like I said, I'm a primary care ambassador. This is a seconded role. My substantive role is as a advanced practitioner for Manchester Foundation Trust physiotherapy. And as part of that level, they invited me to be an ambassador. So, and one of the objectives is to provide advice and support the primary care AHP workforce planning with Health Education England, to support the uptake of the AHP roles in primary care, and provide advice to the PCNs on effective recruitment, retention, training, and education at different stages. So, in order to do that, we'll be working closely with the training hubs, and I know that two of my colleagues as well have been working with Jill to help promote this training packages moving forwards. Okay. Next slide, please, Rob. Okay, so like I said, we debated long and hard how to actually do this, and so we decided to do it a bit differently. Okay, okay, we decided there are too many PowerPoint presentations in the world, so we've created a quiz, which, like I said, will be Mentimeter, of which the code will be on top of the screen. Okay, Rob. Okay, so just as an icebreaker, if you look at the roles that are there, do you feel any of these roles would benefit your practice to the extent that you would want to employ one? Please, can you tick all that apply? I'll just give you another couple of minutes there. The chat's quite active. If you've got any questions, please pop them into the chat and I'll try to, and Paula will try to answer them as we go along. But if not, we'll answer them at the end of the session. Okay, I think everybody's probably responded there, and that's really interesting that there's a spread, which is good. I did expect the physios to be of the greatest dominance, and because we know that that's the workforce that's being employed vastly. And having been a physio myself, I know I may really want to promote the other roles and show you what they can do as well, because they can all provide things for primary care effectively. But it's good to see that there's a spread around. Next slide, please, Rob. Okay, so the idea of this, we decided to do it as a case study presentation rather than me just talking at you. Okay, so this first case study is a 51-year-old man who presents with a 10-week history of painful right groin. He's got reduced mobility, but was recently diagnosed with depression and is off work. Next slide, please. Thank you. Who do you think could assess this patient on initial consultation? Please take all that apply. Okay. Yes, that's great, and it's great that the occupational therapist as well as the podiatrist and physio have been recognised. Nursing associate is good. Obviously, I'm not going to be able to talk about that because it's not my field of excellence, but it's good that we can show that there's a wide range of professions that can help with this patient. Next slide, please, Rob. Okay, so what might this management plan be? Obviously, this is going to depend on what the assessment comes as, but obviously there can be exercises and there's for the hip, depending on what's wrong with it, and hopefully some self-management advice to try and reduce the number of appointments, but the self-management to help prevent chronicity. It's only 10 weeks old, and help prevent a revolving patient. If there may be an investigation required, but hopefully if it's an acute presentation, then the knowledge of the physio who can order the investigations might mean that they might not need to refer for an investigation, obviously saving money from unnecessary investigations, but it's there if required. They could refer on to the physio treatment if this was the FCP physio, because obviously physio in treatment in practice is not part of the FCP role, but they can refer on to the physios as required. Lots of physio and OT with training can issue a fit note to help support this patient while they're off sick, but also more importantly, they would want to promote a return to work advice, and OTs particularly are very good at advisory fit notes to works to practice, so they can work with this patient. We know that he has been diagnosed as depression, and this is a multifaceted concern. So, but all the facets need to be addressed, which these AHPs can do. This significantly shows their knowledge and their ability to do this, and promotes them as a career progression in primary care, of which we know that physio has been there for some time, but not necessarily in a first contact role, and promotes the physios and the OTs moving forward. The OTs, as you have lots of mental health training, and they can help with relaxation, with motivational interviewing, with any products like CBT. They may be trained on this. They are trained in physical and mental support for functionality, but they can also, there's been lots of research to show that they have reduced the load on GPs, the number of follow-up appointments needed, the number of sick notes provided. Clearly, in this ever-growing population and demand on GPs, as Jill said, that there will be a reduction in GP workforce moving forwards. This can help promote the AHPs in practice, but also they can work as link levels with the work to make adaptations as required, to try and make people return to work, so help to reduce it, to improve public health and financial benefits, as we know. Next slide, please, Rob. Okay, so this was a real life patient as well. Okay, this was a 48-year-old lady who presented with insidious onset of calf pain and bruising. She is a student, a mature student, and had travelled over from Poland recently, as she's Polish. Who do you think this lady could see and why? Please tick all that apply. Super. Again, a good spread, showing that there's a wide application of what people can do. And next slide, please, Rob. Okay, so again, what might this be? It might just be a calf pain. It'd be a bit strange with, you know, the insidious onset of bruising and changing colour. Okay, but if it was, it could be self-management exercises. So investigations. Okay, so this is to demonstrate that she's a student, she's static. It was a patient that was a virtual appointment due to the current COVID pressures, and it was an FCP physio that picked it up. However, the physio would then do a well score and refer on to A&E as required. However, you have paramedics that could be in the clinic. The paramedic, if they have a well score greater than 2, they could obviously prescribe as required an anticoagulant, and they could even refer on to the ambulatory team the day after for a Doppler ultrasound, so it never even has to touch A&E. Obviously, in addition to the paramedic and the first contact physio, you've got your first contact psychiatrist, who are have different scopes of practice and different levels, but as you roll in, they would be advanced. As we know, they should be at level 7, as Jill explained earlier, and have done a master's level to show them that they can treat patients to this extent. And they may be able to, obviously vascular trained, so they could have a handheld Doppler and they can make a diagnosis there and then. So this is showing not only do AHPs just do the function and the mobility, they can actually have the ability to recognise masqueraders, because this is not an MSK problem. And this patient was referred to A&E and did have a DVT and was treated accordingly. Next slide, please, Rob. Okay, so this demonstration of the picture is clearly not 84, but you know, add some amusement. So we have here an 84-year-old lady. She contacts the GP by phone. She has a new onset of increasing confusion. She keeps falling over. Is not really fit for the GP practice to make. Who do you think might see this patient as a first contact role in their house? And please tick all that apply. Super. Okay. So this is really interesting to see that obviously the GP can go and see him as a home visit, and the advanced paramedic and podiatrist and the OT. Okay. These patients, obviously, if you could have your AHPs in practice to see this, then this would obviously expand their roles and give them career choice and show what they can do. But it helps to expand your workforce in your practice. But it obviously allows for further GP appointments availability, because obviously there's a significant demand, as we know, with an ever-aging population. Okay, so what might the management plan be? Obviously, your OTs and your paramedics are able to do capacity assessment. Is this new onset as a result of a acute medical problem, or actually is there a capacity issue, which is 84? Has she got any dementia? Is this long term? If it's an acute onset because she's got an infection, the paramedic might do a urine dip. Has she got a UTI potentially? That can do a culture. The OT, as a first contact OT, can have a look at the functional needs, do a gait assessment, as could the podiatrist could do this, do a functional assessment around the house, and signpost accordingly. If she's found to have a UTI, which this patient did, the paramedic can then prescribe. And if there's not an OT there, they can refer on to the ambulatory team and the rapid response team to get an OT and physio assessment accordingly. Should this patient have had multiple UTIs, the advanced paramedic, as the first contact, then can refer on to secondary care as required, as can the OT, as can the physio. And the podiatrist. So this actually illustrates sorry, I've lost my point now. I've lost what I was saying. Sorry, excuse me. Okay, so the point being that obviously this patient can be managed serving in the community. They don't have to come in by people other than the GP. Next slide, please. Okay, so we are trying to obviously put a breadth of patients here to show the abilities of all the professions. This one is a 65-year-old man. He's complaining of pain in both lower limbs. He has increased BMI and a type 2 diabetes. Unfortunately, he has a wound that has not healed. Who do you think can see this patient on consultation? Please tick all that apply. Okay, excellent. Of course, everyone can see this patient, okay, and provide appropriate advice. Next slide, please. Okay, so this patient obviously has got multiple problems. You might want the first contact dietitian and the paramedic and the podiatrist can give advice on wound healing and lifestyle management. They help to promote a healthier lifestyle to prevent progression of these problems, which obviously could relate to reduced wound healing and increase in peripheral neuropathy or peripheral vascular disease, which this patient is presenting with. The podiatrist can do wound management and promote healing within the practice. As this patient's BMI is increased, the podiatrist and the dietitian can work about use evidence-based nutritional advice, what can do to help going forward, help long-term, prevent long-term complications, if and they can signpost as required. Next slide, please, Rob. Okay, so we haven't done, there's not too many of these. I just wanted to show the breadth of knowledge. So this lady is a 55-year-old lady. She's got asthma and high blood pressure. She's got angina and she's not working and she's low in mood. She's feeling socially isolated. Again, a presentation that is multifaceted, that requires quite a lot of input. So looking at this, who do you think can treat this patient? Okay, absolutely. Okay, okay, what all of the above could see, but this is predominantly a OT stroking presentation that can help for the long-term management plan. Can you next slide, please, Rob? Okay, so she's feeling isolated. She's quite low in mood. She's having breathing problems, and obviously she's asthmatic, that needs managing. But the OT can provide all these support for sleep hygiene. What is the best, way she can help with their anxiety and low mood by doing relaxation technique, motivational interviewing, some nutritional advice. They can signpost to community groups just to help increase. Well, not presently in the current COVID, but when it's available, they'll be able to signpost them where appropriate to help her current mood. And relaxation techniques would help her breathing. These are all long-term management plan that help to reduce the revolving patient and reduce the number of consultations necessary, and hopefully if it can help mental health, and then potentially help to get her back into work. She's only 55. Okay, next patient, please, Rob. Okay, so this is a patient who, again, is a true patient. So 54-year-old gentleman who presented with an 8-week history of thoracic pain after he lifted a tire. Who do you think could see this patient as a first contact? Okay, I think everybody's responded there. So this patient was seen by a first contact physio on a virtual appointment initially. Can you have the next slide, please, Rob? Okay, so you might prescribe exercise if you didn't think it was anything significant, or refer on to physiotherapy in the community. However, he's 54 and he's got thoracic pain, and so this patient did refer for an X-ray, and it came back as expected as a wedge fracture. So you might think, oh well, my job's done there. it isn't a wedge fracture as the FCP thought it was. However, if this therapist was not at an advanced level of knowledge, so they weren't at the level 7, they might have left it there. Okay, so they've diagnosed that it is a wedge fracture, and it looks stable, it's okay, we can manage it appropriately. But the deeper level of knowledge, they thought, well, he's only 54, he's male, he shouldn't really have a wedge fracture at this age. I think we need to investigate further. So they sent for bloods and sent for an MRI scan. He did have elevated immunoglobulins and did have a myeloma on MRI scan. This patient was then stabilized within 3 weeks, and by referring to the 2-week rule, and there was no multiple myeloma found. So actually, this just shows the level of knowledge required for the employment into these roles. Invariably, people don't know what they don't know, so it's very important that you ensure that these people that you employ are advanced clinically and at level 7, as Jill was describing in the clinical pillar. Next slide, please. This is just another question. Did you expect the AHPs that I've discussed in these case studies to have this level of knowledge? Please answer yes or no. Okay, I think that's going to be all that's going to answer that. It's quite, I'm pleased that some of you did expect people to have this level of knowledge, but equally pleased that some of you didn't. Okay, because then hopefully this presentation will help everyone realise that the level of knowledge that people should have and the what they can provide. Okay, so as Jill was saying, I don't want to go over everything that she said, but the roadmaps have been produced. They should be at a minimum level of 7 academically for the clinical pillar for your FCPs, and progression on to advanced practitioners if they're at level 7 for leadership and research and education also. But it's not just about the academia. We all know that we learn on the job. It's got to be their experience as well. So they need to be at least 3 years qualified in that field. So a physio, for instance, will rotate for 2 years. So you don't want somebody who's just 3 years qualified because he wouldn't have been 3 years qualified in the MSK field, and they wouldn't have that level of expertise. So it's about that they are at pay level scale band 7, so they're at pay band 7 minimum. So they're on the agenda for change. So they've actually climbed through their experience from a band 5, band 6 to band 7, and they've achieved a level 7 master's qualification. Next slide, please. Okay, so this is just a summary slide of some of the things I've said. It's about seeing the right person, the right place, the right time. Clearly, GPs could see all of the patients that are presented today, but with the current demand and the expertise that's out there, it would be it's great to see that we can expand the workforce and use these roles in primary care. As an ambassador, I'm working with the higher education institutes as well to try and promote FCP role development courses so that it can reduce the demand of supervision in primary care if they can get a level 1 and level 2 within the university. And we're hoping to go out earlier. Obviously, we've been restricted this year because of COVID, but we would like to obviously get in with the schools and the further education colleges to promote primary care as an option within the fields of physio and OT, paramedics, dietetics, and podiatry. And this is just a summary slide of what some of the skills they can do from what we've discussed today. Last slide, please, Rob. So after what I've discussed today, just a comparison to the first slide, would you want to employ any more or any different to what you said at the first slide? Okay. I suppose it would have been good for me to be able to remember what you said on the first one, but I can see that there's actually been an increase in OT, which is great. Okay, and the podiatry, but obviously these it will be the results will be available for sharing afterwards.
Joanne,
yeah.
it's Paula here. I was keeping track. Do you want me to do a tally? Do you want me to just quickly say?
Yeah, it'd be interesting to say.
Before
Please.
and after.
Thank you.
Okay,
yeah.
So
I should have wrote that down. Sorry.
No, it's fine. You've been busy. So beforehand, 15 said that they would recruit a physiotherapist, and that's gone to 11. Occupational therapists started at 5, and that's now increased to 9. Dietitian started at 9, and that is now 6. Paramedics was 10, and that's now 7. Podiatrist was 5, and that's 4. So yeah, some have reduced, but I think it does highlight the potential lack of awareness of what an occupational therapist can bring to the party. But it's looking, it's looking quite well rounded for all of the professions, isn't it?
Which is good, because we do want to promote all of them, and then obviously it'll be different on your locality, it'll be different on your patient cohort, because everybody will have a different demand, but it's just to explain and illustrate what everybody could do.
I wonder if I could come in with a question here, kind of MC's prerogative, which might, I don't know whether it's on other people's minds too, and might be one of the reasons why the numbers haven't, say, gone up for, say, something like first contact podiatry, because I wasn't entirely sure with the cases, not what the right answers were, because I know that's probably not really the right concept, but what, say, for example, a first contact podiatrist could offer for some of those cases. Because I know when we talked, obviously preparing for the session, what was the big surprise for me is that a first contact practitioner, which with whatever their initial profession, has now become someone who's able to see almost anything at first contact, because they've taken their skills to a higher level and they've got a great awareness of their limitations and the roles of others. Now, I may be mistaken in that, but if that's right, that would be a really nice kind of message to get across, that once somebody's trained at first contact level, regardless of what their initial profession was, they're now a suitable first contact person for a much bigger range of presentations. Is that right? And can you expand if it is?
I would say that's right if they're within that field. So the study that they do as a first contact is so like the level 1. I'm sure Jill can pop in here if I'm mistaken on anything. Is that it's more the stage 1 for any first contact. So they've got to have good awareness of red flags, or good awareness of dealing with pain, or so there's the learning modules that they have to do is a wide scope. I wouldn't say that every profession can do the other part, but what they can do is refer between them. So I wouldn't say that a physio, for instance, is very good at mental health assessment and helping with mental health support. So I wouldn't say that particularly the patient with the who was really low in mood and socially isolated, and I wouldn't say the best skill physio would be the best skill set to do that. I would say the OT would be best skill set to do that.
No, because I think that's one of our challenges. I know with the GPs on the call and the community pharmacists, who I guess are generalists, and there are a few of us left in health, I think, is that we need people to be acting like kind of generalists, and it does sound like to a large extent these professions can offer that, but then to a certain extent we also need to be a bit selective. Is that a fair judgment?
I would say that's absolutely a fair judgment, because the whole idea really is that you exploit the skills that they've got individually, but also that, you know, you might, for instance, if the OT had gone to see the lady with the potential UTI, they couldn't do the urine dip. They're not trained to do that, but they might be able to signpost to the right person.
Yes, so a little bit in the chat, because there will be some places where our where knowledge differs between groups, and I guess that's a good opportunity for learning and training. So particularly around dipsticking urine in the elderly, are those GPs on the call will cringe a little bit at the concept of dipsticking wee in the elderly, because it's always positive and doesn't necessarily mean a UTI. But so I thought I'd have to pick that one up a bit because it was mentioned in the chat.
Yeah, I suppose they've got to put every single thing together, don't they? But
kind of learning
holistic. So no, I wouldn't say that. I think your generalists are really your paramedics, which are, you know, out the five, because we know that they have to deal with everything that they go out to. But actually, OTs, physios, podiatrists can see a multitude of things. But they can hopefully they'll be able to refer between themselves and refer to the pharmacist if they themselves are non-medical prescriber, although some are. They could refer to the so the idea being that you work in a multidisciplinary team, that you can all work together, but you can share your knowledge between each other, so you become embedded in practice, and you can teach each other. But it's about reducing the demand on the patient journey. They get fewer investigations, fewer DNA, fewer turn-up follow-up appointments. So we know that the GP demand appointments is huge, and this will help, as well as providing career progression for all these talented people, workforce that you potentially got there.
Can I just give Jill's one to ask a question, I think, just before we finish off this section, Jill?
Yeah, and I think this is a really important point, because these are experts in their scope of practice. So from my point of view, getting a patient with an MS case problem to see the first contact physio, they're going to get a far better deal than they're going to get from me, because that's their experience, that's their expertise. And what we as sort of the PCNs, the GPs in that, is work out how we get the right people in the right places. Now, whether that's signposting or whether that's self-referral of the patient, but these guys are experts in their scope of practice. And as Joanne said, the paramedics are probably going to have the broader, but that's up to us to how we develop that role as the PCN, and how that paramedic might fit differently with one PCN than another PCN. But they are experts in their own right, and what we need to do is just make sure that we get the right patient in there. And these guys, because of their breadth of experience, will then know how to signpost that patient to another professional if they're not in the right pot, if that makes sense.
That's great, Jill. We've had a good plug for wider therapy teams from Liz Foster from Oldham in the chat, which is great. Now, I don't want to cut our next speakers short, so I do want to also, though, before we completely wrap up, give a plug to some webinars that the workforce team are running related to additional roles and allied health professionals, which could be of interest to anyone. And I'm thinking, I know we've got quite a few community pharmacists on the call today, which is fantastic. And I know from talking to Ricky that it's an interest of all of yours to know who to signpost people to, because your traditional model, when you've reached the scope of what you can offer within your pharmacy environment, would be to get people to contact the GP. And so it's actually crucial for this whole primary care network system to work, is that you have equal awareness to the general practice about what else is out there. So so really thank you so much for joining us, and if you can join any of the webinars as well, that would be amazing. So thank you very much to Joanne and Paula and supporting her. That was really interesting and useful. So I'm going to now hand you over. I'm not sure if I'm handing over to Claire or to Nav, but I'll let them introduce themselves. They are guests not from the Greater Manchester area, so we have to be on our specifically best behaviour today and show them how fab we all are. And they come representing the National Association of Primary Care to talk about the care programme, wider roles, population health, whole range of things. I will shut up now and hand over to whichever one's going to take up the mantle first.
We're both pausing to see which one does. I think I win. Hello to everybody. I'm Claire Simpson from NAPC, as Joanne has just said, and we do. It's been really great for me. I've joined you for the whole session, and I've really enjoyed it. And now I've learned about Mentimeter and all sorts of great technology that we might start to use with some of our presentations. But Nav is going to start us off talking through population health management and how that might actually start to bring some of the discussions you've had today all together. And then I will talk later about the care programme that Joanne has mentioned.
Thank you, Claire, and thank you, Joanna, very much for inviting me in particular and to have a chat with you. So Joanna, there's no need for you guys to worry about being on best behaviour. I've been following and admiring the progress that's been made in Greater Manchester for many years. So please, no need to worry about that. Just for colleagues who don't know me, I'm a GP in South London, and I've been involved in a variety of sort of system type roles over many years. I've been the former chair of the National Association of Primary Care, which is, I guess, why I'm here today. But essentially, what I wanted to do, if that's okay with you, Joanna, and your colleagues, was just to share some perhaps personal experiences around this whole landscape of population health management, and just to see if any of it makes sense. It may not, and that's fine. But just to sort of see if that helps us a little bit more in terms of how we incorporate our friends and colleagues from different sectors and in different roles to work together in a more collaborative space. Does that in principle sound okay, Joanne? I'm looking at you just to nod. If you think that's not on the ticket, then we'll move on to something else. So I'll just tell you sort of my why story around all of this, and it's fairly recent. I think about 6 years ago, like many of us, I was perplexed as to why the demand, particularly through my practice, we were never able to kind of manage it or kind of get on top of it, no matter what we did, no matter how many more doctors or nurses or other colleagues from different professions we tried to employ or recruit. We were always on the back foot. We could never quite catch up with that story, and I'm sure that probably resonates with many colleagues across this piece. And then at the same time, I figured out after now a 29-year career in general practice that the health inequalities of the patients I've been looking after over that time, those who've survived, have actually got worse, not better, over the career span of my professional career. And before, Joanna, you commented that it's anything to do with my medical practice, I kind of started to wonder more about what are the actual determinants and things that actually can make a difference to that health inequality agenda, rather than just thinking about my role in a medical practice. And this is all pre-COVID, by the way. And obviously, as a result of COVID, we've learned a lot, haven't we, about this whole issue around health inequalities. And in fact, as many colleagues will know, the whole approach to the pandemic through the health service has been a massive exercise in population health management, hasn't it? It's been about identifying people at various categories of risk. It's about segmenting them into the risk categories. Even the vaccination program is a classic example, isn't it, of how you use age and risk factors to segment people into particular categories and prioritize their care. And I guess that's population health management in action. So it's really just following on from that, really, in terms of how we incorporate the great skills and competencies that you all have in terms of the agenda of population health management. So without waffling anymore, and just to outline, we've got a sort of three-pronged attack on this session. So there's a little bit of more waffle from me, if you can bear it for a few more minutes. Then it'd be an opportunity for us just to sort of reflect on some of the things that we've heard about, and then Claire is going to talk very specifically about the care programme and its opportunity to create an environment in which population health management approaches can be kind of developed using it as a starting point. General practice nurses as a sort of catalyst and facilitator to make that change happen. Now, again, Joanne, I'm just looking for you for feedback. Does that sound okay? Right. Okay. So I'm now going to try and share my slides. Now, is that technically feasible? If I'm able to do that. So here we go.
Yes, that work fine.
And Joanna, can you all see that slide?
Yeah.
At the moment.
I can't. I can still see faces.
Okay. So I need to do a screen share thing.
Yeah. If you use the screen share at the top right, it should work.
Oh yeah. Just trying to find it on my thing. There we are. That should work now, shouldn't it?
Got it.
So Joanna, I've also got you on the bottom right of my screen, and if it's okay, I'm just going to be looking to you for feedback as I go through that. Is that all right? So this is in the form of a narrative, and I guess what I'm trying to share with you, and forgive me because I know many of you have been leading the charge on population health management across Greater Manchester, and I please don't want to talk in any way to people who already understand some of these concepts really well, but I'm just trying to frame this in the context of some of the work that we've been doing very locally in my practice and our neighbourhood, to try and introduce some of these concepts so that it doesn't sound the language doesn't sound so alien to people, particularly working on the front line. So just going back to my point about health inequalities, and again, we all know, and this is my reflection, that when I think about what really contributes to the health of the population of East Merton, where I'm a GP, I've realised only too late that only 10%, arguably, of the things that we do within healthcare make a substantial difference to the health status of the population. And Joanna's nodding because I'm sure you're very aware of that as well. And I guess the things that make a difference to the population that I look after are, stable housing or good quality or good enough quality, people having work, or people being in some form of employment that sounds meaningful, and people having stable relationships with other people that demonstrate that someone cares about them. So those three factors make a massive difference to the population of East Merton in terms of the overall health status of that population. And then, of course, there are other things such as education and nice environments and having transport and so on. So if 90% of what makes a difference to the health outcomes of a population are non-health related, I think it just really makes a difference in terms of how we think about how we organise our care delivery approaches. I hope that's okay. So as we then move on, colleagues, what I'm trying to talk to you about next is how we really start to build up a really rich picture or richer picture of the population that we look at, whether it's your practice population, whether it's your neighbourhood or PCN population, or whether it's your population across your commissioner or CCG boundary or local authority, and whichever sort of approach that you wish to look at, it's really thinking about how you build up a rich picture. And some of that rich picture comes from the knowledge and understanding that we have as individuals of patients and how they live and where they live and so on. So it's qualitative information, and some of that information comes from data that we can gather from various data sets to help us kind of identify those people who might be at risk of particular events. But it's both qualitative and quantitative information that helps build up that rich picture. So forgive me for this, but the next couple of slides are going to be slightly generic and a bit passive in terms of what I'm going to say. So I just wanted to be clear about some definitions that I think myself and our team and our practices have found helpful. So the first is to try and sort of draw a distinction between population health and population health management. So population health is, in my view, a wider aspiration of how we improve the health of an entire population, try and address the health inequalities that sit within it, and in some way trying to address the broader determinants of health that I was referring to earlier. Joanna, does that make sense? Do you think that? Okay. The difficulty of that is, of course, a lot of the input that's needed there is beyond the control of individuals like me and colleagues within my practice, because it's about civic level interventions, maybe national policy, maybe kind of thinking about things at a wider regional system level. And of course, that's not to say that that isn't important. That's really important. But it's you know, what can we do practically in our own backyards that can make a difference? So if we then flip over to the kind of population health management section of this slide, this is really about chunking a population down into small chunks or small groups of people who share common characteristics. In the parlance, that's known as developing or creating segments of the population. It's a really unpleasant and horrible word, but essentially it's about identifying a group of people who share common characteristics, and we can all agree what those common characteristics are. But having identified that group of people, it's really then starting to think about planned or proactive approaches that can be put in play. So not just dealing with the demand on the day or the issue of the day, but thinking about things that might be preventable in the short, medium, and longer term that might make a big difference to the health outcomes for that group of people. And of course, none of this is done on an individual basis, so we can't solve this problem on our own. It's really about how we work across the multi-agency way, and I stress that because when Claire Simpson talks to you about the CARE programme, this is really about encouraging a very broader multi-agency style of working, which I hope incorporates that wonderful dialogue you've been having about people with different skill sets from different backgrounds and different roles. So the multi-agency concept, again, just visually is thinking about if we're looking at a neighbourhood level or a community level, let's say around that 30 to 40,000 population that we are targeting within our networks, is kind of what are the agencies or who are the agencies that can meaningfully play a big role in helping us address the care needs of that population. And this is illustrative, so don't panic if there's a sector that's not represented here. That's why it's a jigsaw. It's in the process of being built. But you know, there are a number of agencies or a number of sectors that have an impact, don't they, on the health and care status of our patients, our carers, our communities, and starting to think about how we can engage with them in a sort of meaningful way that really helps address the challenges we face within our practices. Joanna, does that all make sense so far? Okay, thank you. So if I then move on to the next slide, whoops, skip that. The challenge with population health management, as I've seen it, is that sometimes what we do is when we segment people into particular groups, the focus just tends to stay with that particular group. So we tend not to think about the whole population and what can we do in terms of impact across that whole population. So yes, of course, we can start from somewhere, but then the idea is, particularly if we're looking at a network size population of, say, let's just say 30,000 people, how can we help identify the risk that sits across the whole of that population and gradually over a period of time make an effort to try and address the risk across all the sort of subgroups within that population. So this framework we developed at NAPC a few years ago was really just to sort of say there are many ways in which you can chop or chunk a population down into more manageable chunks. Okay, so here we've just used a very simple classification. One axis is a life course axis, which I'm sure colleagues will be familiar with, you know, children, young people, working age adults, older people. The other axis is a sort of functional health status axis, which is people generally thought to be well or without any significant risk factors that we know, people with, you know, stable long-term conditions or social needs, people who've got, on the far right, really significant complexity or multiple physical or psychological or social factors that play that through. And having kind of broken that population down into those categories, it's then really within each of those boxes, perhaps understanding the need of those people, engaging those people as much as we can, thinking about what their planned proactive care needs might be in a sort of management sense. And then once we do something, thinking about whether we're making any effective impact in the health status of those people. So that really is the building block of population health management. And as I say, you can apply that at various levels, single practice populations, network populations, or indeed CCG populations if you wish. So the next slide And this is just applying that to essentially 2 practices, one mine and one other in our neighbourhood. We've not been able to do this across all practices, but just to give you an idea of some of the percentages that sit across those 9 cells that I showed you earlier. And what we've tried to do here, because obviously staff were interested, is look at where the demand is coming from. So which particular group is causing demand in terms of GP contacts within the preceding 12 months. So again, I'll leave you to reflect on this, but arguably the majority of people in East Merton are fit and healthy, arguably. So that very much spans the majority. And of course, when you look at GP contacts across that fit and healthy column over the last year, it's actually relatively few compared to people across the other end of the scale, where we're talking about people with significant physical, psychological or social care needs. Now that wouldn't be a surprise to anybody, I'm sure, Joanna, that wouldn't be a surprise to you, but I guess if I look at that top right hand box, that's less than 1% of the population, we're actually talking about numbers here around 400 people. Okay, so these are young people with significant health and or social care needs, perhaps. So 400 people across a population of 20,000, we know who they are, we know where they are, we know where they live. We can start to kind of think about how could we organize a planned approach using a multi-agency way of working, using all our colleagues and our professional attributes that we know of to support us in that way of sort of thinking about how we could address the need going forward. I hope that makes sense, and this is purely illustrative at the moment. So the next slide, this is very much taken from my practice, and I make no apology here about the way that I've presented this, or we're presenting this. We've used a colleague who's a really skilled analyst to do some of this work. So, but what we've done across our practice is say, look, there are five categories of people that we're really quite interested in. It doesn't matter what those 5 categories are. That's very much for colleagues to discuss within their own environments and say, look, we're really interested in these people. We'd really be interested to know how many contacts this group of people, this segment of people, have had with the practice in the last 12 months, whether it's going up or down, and then starting to think how we as a group of colleagues can work together to maybe address some of these needs so that we can see a change in demand potentially, and also an improvement in the health status of these people. So if I draw your attention to the second row here, 35 people we think are vulnerable with mental health issues and whose demand, if you can see, is significant over the last 12 months. So that's 35 people across a practice list size of 12,000 that we could meaningfully start doing something about. And I'm not saying who should do anything about this. It's just who across our team can we start looking at from the point of view of a planned proactive contact that we can start to make a positive difference, to understand their need better, and perhaps start to think about what types of interventions we could design together that might make a meaningful difference to that group of people. And of course, the answer is, once we've done something like that, is to, if we've learned anything from it, is to see if we can then apply that to other categories of people, and so we can learn much more as a network about how we bring to life this population health management concept. So I'm nearly done, guys. And so Joanna and colleagues, I've always reflected that, and I've been involved in health education in some way for a number of years, is that one of the challenges for us is that we need people with different skill sets that sit within different roles. So we clearly need to do that, and we need to understand that. But if we're going to make a fundamental difference using a population health management approach that I've been describing, we need to also start thinking about, if we identify a group of people or a segment, let's just say in this context it's frailty, what are the care functions for a group of people in that category? And here is, again, purely illustrative, some care functions that might be applied to 20 or 30 people with significant frailty needs. And of course, if I've missed something out or I've mislabeled it, please forgive me. So the idea is then, who across our team currently do we have that can help support some of those care functions? And if we don't have anyone currently available in that role, is there anyone from another agency we can have a chat with to support us? And if still we don't have anybody who can support that particular sort of function, what can we do in terms of education and training, peer support, professional development, supervision, and so on, to develop that particular skill set and address that function. But having done all of that, how do we create a really productive, effective team of people that feel empowered with a sense of belonging, feel supported, energized, to kind of make a fundamental difference to this particular group of people that we've been talking about. And I'll just leave you with this final slide, because essentially, in terms of my own journey and the journey of people within my network over the last few years, it's really been moving from those sort of sections on the left to the sections on the right. I know that probably all of you in Greater Manchester have probably been on this in a much more effective way than I have and we have, but essentially, I think that kind of mindset change has been really important to lift us from dealing with the need of the individual in front of us, which is still very important, to taking a broader population health responsibility for a group of people and our wider population. So Joanna, I'm going to stop there. This was just by way of just, I don't know, having a bit of a waffle with you and to see if any of that makes any sense. It may not, of course, as I said at the beginning, but really, if people feel there's some sort of merit in this sort of method, how can we start to liberate this a bit more? And Claire will talk to you a little bit more about how the care programme itself can support that. Shall I just stop there, please, for a moment?
Thanks, Nav, that was really great. Sorry, Claire, did I cut you off? Were you going to come in at this point? I was just going to work out whether you're taking over straight away, or whether Nav wants to see whether there are any questions at all.
John, I was just wondering whether I could just get a bit of reflection from people. I mean, it doesn't have to be anything forced, but if there's, I mean, again, there may be some great work going on already that you as a team are wanting to showcase or celebrate. Just to illustrate these points, perhaps.
I think it would be lovely to make it real within a Greater Manchester context. Indeed, I think you're absolutely right. Is that right, Claire? Is that what we were going to be doing at this point?
I think it would be really great to share some examples. And Nav, I wonder if you could stop sharing your screen so we can see more people, and that would be great as well. Thank you.
Because sometimes you've presented it really well, but for some people this will be a real concept, and for some it might still be quite abstract.
Sure.
In terms of what it means in reality. So I know we've particularly invited Juida Nidhi, GP from Stockport, onto the call because of some of the work that they've been doing related specifically to a kind of population approach to health. So it would be just great to hear what's happening there. But actually, I would also absolutely love if anyone else is on the call and they know that they're doing something or they're aware of something within their network, neighbourhood area, where they're looking at more of a wider approach to health other than treating a presentation, then that would be fantastic. So please make yourself known in the chat, and then I'll introduce you to tell us about it after Juida's told us about her experiences.
I think there's a lady got her hand up there.
Okay, I think if you go first, Juida, and
oh, you want me to go first? Sorry.
Sorry,
I'm just waiting for.
Yeah.
Okay.
You
Okay.
first, and you tell your story, and then we'll hear from some other stories as well. That would be great.
So I think it really lends itself to those social determinants and wider determinants of health. I will talk later after Claire about the care programme as well and our practice experience of it. But in terms of population, what we focused on was demand, GP demand, because we were really struggling. And so we focused on who were the most frequent attenders with a quick search, computer search on our system, and found that the majority of them, and Nav has highlighted this, tend to be older people who live alone. They're in a single household, as we said, live alone, and they have very little support around them. And yet we had one who'd had more than 50 contacts, Mabel, within the practice. So our approach, which was as a primary care team, so really nurse-led, but also with our practice volunteers, was to really start to have a person-centred approach with that individual. What matters to you? So it lends itself to those developing a self-management plan, co-producing it with the individual, and involving them in social activities, because the biggest issue for that person was loneliness. And so the practice became the place where she went to because she had nowhere else to go to. And we found that that is actually a recurring theme with a significant number of our older people at Alvanley. And so the practice champions focused on events like we have an allotment, a singing group, walking groups, knit and natter. I like the singing group because I can go and sing Tom Jones' Delilah, so I try not to miss it. But it's made the practice very community focused. But what actually is measurable? So in terms of quality improvement, Joanna, you'll like this, our triple aim. So in terms of our patient outcomes, our patient experience and best use of resource, by having that approach, and the wider team, I would say, includes our patients. Our patients are part of that wider team, and they have developed different ways of supporting those social determinants, working with the link worker around the housing and access to employment opportunities, etc. So we saw a reduction in GP attendances and also a reduction in A&E attendances. And I don't know why, but a reduction in outpatient referrals. So Mabel was incredible. And even then, during COVID, what we found was that our isolated patients were really struggling because they couldn't get out to the activities. So then we quickly adapted to using Facebook Live. And if they didn't have a tablet or an IT device, we worked with our mutual aid group and council and provided them with tablets and coaching by the volunteers, of which in the end there were 500. And these individuals could then use a tablet, speak to relatives they'd never seen before in Australia in their entire lives. Honestly, we were all crying because it was just so amazing. But they also learned how to order their prescriptions using EPS. And so we moved to 100% EPS. So I mean, I've done it a very slow, I've done a quick kind of fire story, but we've got videos of Mabel. And all I would say is you start with population health management, you use the data, you identify them, but your approach has got to be one that is really holistic and involves the wider team. And please make sure your patients are the wider team. So that's.
Thanks, Joida. That's great. And we've got a couple of other stories that have appeared that for sharing in the chat. So I think Delamere practice, is it Trafford?
It's North Trafford, yeah.
North Trafford. How do you want to tell us about your story?
Of course. I'm a PCN manager for North Trafford, so I'm not a clinician myself, but actually my story is quite similar to Joida's in terms of social prescribing. So in order to address the health inequalities in our particular locality, maybe we don't have that holistic population health approach just yet. But I think social prescribers have really revolutionized the way we approach it. They've made an absolutely huge difference of being that proactive, focused group on specific things in our population. And the specific example I wanted to give was a patient who's 38 years old and was having 4 contacts with the GP a month. And then we also know they were having repeated A&E visits as well. They'd been in the country for 20 years as an asylum seeker, and within 2 months of being referred to social prescribing, they were able to get their refugee status, which meant, I think in the first month, his contacts with the GP service was halved, then it was quartered, and then it almost whittled down to almost nothing. Of course, they still have continuing needs, and of course, both clinicians and social prescribers kept working with him, but it meant that one issue, that one big contact that the social prescribers could help with absolutely made a huge difference to his life, and it was covered in the local press as well and everything. So it's only one step, an example of one patient, but social prescribing in particular in North Trafford, I think, has been our key motivator for looking at this slightly differently. Thank you.
Oh, that's brilliant. Thank you so much for sharing. And I think that you say it's kind of small steps, it's one person, it's just sometimes a single experience can change the mindset of everyone that works within that, so that it replicates. Liz, do you want to tell us any bits and pieces about what's been going on in Oldham related to population health?
Yeah, thanks, Joanna. Well, there's a couple of things. At the moment, we're looking at population health to be rolled out across the different PCNs as a tool to use going forward, much in the way that that Nav described. At the moment, it's being done sort of at a higher level with 2 of the PCNs, unfortunately not with mine. but we're still sort of being drawn into some of the discussion. And for me personally, it's something that, you know, sort of I'd known about previously and was very sort of focused towards that. And the other thing that's going on in Oldham, which is a big thing, and particularly for my PCN, is that we've got focus care, which I don't know whether, Nav, you're aware of the focus care programme. It's something that came out of Hope Citadel, which is the organisation that I work for, but has now been rolled out on a wider footprint. And I'm really lucky in my PCN, because of the level of deprivation, that we've got focus care practitioners in every practice. That has meant that we've not had as much need for a social prescriber. And we did try to sort of divert the social prescribing money to a slightly sort of different usage, and got some kickback on that, which I was a bit disappointed about, because I thought, you know, it was somewhat inflexible, but that's another issue. But as far as the focus care is concerned, you know, I think there are lots of benefits from that, both for the patients and for the clinicians. I think the loneliness issue that Dr. Idu picked up on in her area is something that has really been, you know, is a big thing, and has been magnified during COVID. And I think the other thing that particularly the focus care workers have picked up on in COVID, because they've had to work in slightly different ways, has been the massive amount of need that they've uncovered in people who weren't really accessing general practice at all. You know, sort of, they were sort of getting on with their lives, but COVID has precipitated a crisis, which has then become a you know, medical mental health crisis, and has you know, the amount of need of people who were surviving but almost at a subsistence level, but not coming into services, that has really you know, that's really been a big change. But the other aspect of focus care is that from a clinician point of view, and particularly from a GP point of view, I think that's the one thing that has kept certainly some of the older people like me in practice, because it's been a way of being able to sort of delegate, you know, those really difficult patients for whom, you know, it's difficult to juggle all their individual multiple needs, and to be able to direct them, signpost them to a focused care practitioner, you know, sort of, who can give perhaps even more input than a social prescriber can, you know, has really been very important in the last few years of my career.
And thanks very much, Liz. I'm particularly struck by what you said about keeping us in practice. And I think as for the GPs and community pharmacists who are kind of frontline primary care, we know often who these people are. And then if you feel that you don't know what to do, it can just be professionally very demoralizing. But just because we don't know what to do doesn't mean there won't be somebody who knows what to do. And I think that's a really kind of an important message. Now, I do know, just because I'm a bit mindful of time, and I've got Claire Simpson smiling at me, I know we need to give her a chance to tell you all a little bit more about the care programme, which is available in Greater Manchester. Oh, sorry, there's something important in the chat. I was aware, Liz, that not everybody knew what focused care was. Now, I haven't got, unfortunately, I know you could explain what focused care is, but it would take you about 10-15 minutes, and we don't have that time. If whoever's asked that question, oh, it's Paula, I will try and pick that up with you outside the room, but it's specifically a complex need. It's a worker who just focuses on complex families and complex needs, basically, somebody allocated to them is the brief say. But I am going to hand you over to Claire, because I do want to make sure that we finish on time.
Thank you very much indeed. And to, you know, what we've just experienced is very much the approach that we want to take with the care programme. It's much more about your stories. It's much more about what's happening in Greater Manchester, what's important to you, and how we can actually support you to really focus on those priorities and make the difference you want to. Jill mentioned earlier about some of the issues you've got around your GPNs, and a lot of them coming towards their retirement age. So care was actually commissioned by the GPN 10-point plan, the NHS England NHS Improvement Programme. And so it did start with an absolute focus on general practice nursing, and I know in Greater Manchester you are retaining that focus. But we are absolutely, as Nav has already said, it is about general practice nurses, in fact, acting as a catalyst for change. And listening to your stories, the point that I think we've been hearing is it's the function rather than the role that the people are performing that is important. So social prescribers, whoever it is that's having those conversations, it's the conversation, it's the health coaching approach that they're taking that actually is making the difference. And as Nav has talked about, it's that proactive approach to care, which we have through all of the data and the evidence that we've been collecting through the care programme and other work that we're doing with primary care network development. Nurses are driving a lot of that. That is a function that they absolutely perform, and they connect your workforce in a fantastically helpful way. So it's a really great place to focus on your general practice nurses and to bring them together. The way that we are working with them is we've actually developed care in conjunction with, so it's a co-design with a local system, Bedfordshire, Luton, Milton Keynes. So we've actually designed it with general practice nurses, with primary care team leaders, training hubs in a local system, and we did it during COVID. So we started last May, so it is entirely connected into what's going on now, and absolutely about making it accessible. We know that it's difficult for people to get to things, so we have we're running it all online. It's 2 hours a week there are 8 sessions, topped and tailed by a launch event and a celebration event. And in those webinars, we deal with 2 different aspects. We deal with self as leader. So it's all your own confidence, what's getting in the way of you being the very best person you possibly can be, what's stopping you impacting well with other people. Why, stop being a victim, actually say, I have got a difference to make, and I'm going to make that difference. So empowering people through different ways of thinking and seeing themselves in their world. And then that is connected absolutely wholly and squarely with all the stuff that Nav's just gone through. So from an NAPC perspective, we help your nurses, your participants, to see what they're already doing, what they're already amazingly brilliant at, all the ideas that they've already got about how they can make a difference. And we wrap the support around them so that they feel that they can get on and do it. They've got national connectivity, so CARE stands for connected, authentic, resilient and empowered, and the connected piece is critical. So they get national support, they get expertise from the national bodies, but also the national teams learn so much because they're hearing what's happening locally, what works and what's necessary. But the nurses feel so valued because they get their nurse leaders coming to talk to them and listen to what's going on for them, and to get involved in their learning. And that final bit, the final element of care, is that it is about connecting your system to the participants. So they're not just doing their learning in isolation, they're doing it with you. As system leaders, you get involved. And so what we were so delighted about being invited to see you today, because as those system leaders, we really want you to engage in the programme and to get actively involved in it, to find the GPNs that you want to send along to start to learn. But you can also be part of their development journey, and we would love you to be there and to come along to the webinars, share your stories as you have done today. So I'm going to stop now, Joanna, because of time, and just see if there are any questions about that, or whether you want to add anything about how people can get involved.
So I think questions that have been appearing about other things have gone in the chat, and I've been trying to answer those as we've gone along. And Liz has posted something useful about focus care for anyone that wants to read that. So so if anyone's got any specific questions about the GP practice nurse care programme, just bung your hand up now, that'd be helpful. If not, I'm going to do a bit of a summary. So I thought rather than kind of prepare a wrap up for this morning's activities, I would scribble some things down that really struck me. I partly did this because I think if anyone's ever listened to the Primary Care Knowledge Boost podcasts, which are done in collaboration with GP Excellence, the thing I love about the two women that run that is when they have a chat afterwards about the things that they learned from the conversation with the expert, because it helps you to process your own thinking about what you picked up. And so I thought, okay, things that I didn't know before the start of the morning and that I feel I know better now. And well, one of the things that struck me from Jill's talk was that nurses, as part of their professional revalidation, they need to demonstrate that they're using and maintaining their supervising skills. Now, I didn't know that. And actually, I'm thinking, how often do we give them that opportunity to do that? So this is involving our nurses within our wider PCN team in terms of a training environment. Well, that's the best win-win, isn't it? So, we need them, they need us to give them that opportunity. So I thought, I'm going to write that down. That's fantastic. Another thing from Jill's talk earlier that struck me was the minefield or maze. I was seeing mines in a maze field or whatever, of navigating the processes to become a training environment for all the different levels of training. Now, it did look like there was a massive move on making that simpler, and that really kind of resonated with me, because I think for those of you that are PCN business managers that are actually thinking about and making sure you've got the right processes in place so that this can happen, you don't want to be treading through a minefield. You want something that's really kind of simple and that you can navigate. So I thought that was great to hear. The first contact stuff, now I think that's a game changer for me in terms of how we view wider roles within primary care. And I think it'll require for the community pharmacists, GPs on the call who kind of know their role and have been used to being the kind of first contact and the generalist by so many people, is that we as professionals are going to need to change the way we think. And we are going to need to give permission to other people, other professionals, to work up to the full level of their expertise. And of course, that for us to be able to trust that that's going to work, we're going to need a little bit of knowledge ourselves about what that person can or can't do, so that we can trust their skills and learn to develop that team approach. And I think that's going to take for me and for many of us maybe just a bit of an attitude shift, that we're going to really need to welcome that and give permission and develop it. Because it's going to wobble at first, like these things do, and that we mustn't feel that just because there might be some wobbles initially that we can't get it working. So that struck me. Nav's population thing, I loved the slide on we're moving from roles to teams. And I think the reason that really resonated with me and many of you on this call, although maybe not those who aren't on the call because they're probably busy doing them, have been involved in setting up and running vaccination clinics for COVID vaccination, where everybody's been redeployed. We've all been using people's wider skills, and all of a sudden we're not roles, are we? We are teams. When a day runs well in a vaccination clinic, you end that day exhausted and absolutely exhilarated, and it's because it feels very much like it's not about the roles, it's about the people and the team. And I think we've got an opportunity to really build on that. So that was fantastic. And then finally, this is obviously a plea, because as GP Excellence, we're helping to run the care programme with the National Association of Primary Care for our GP practice nurses. So we are genuinely looking for a GPN from every PCN area. We want 67 to go through this programme across Greater Manchester, so that each PCN has got someone who's developing those skills to be able to collaborate and to have their voice heard in their network area. So if you are involved in any way at that kind of PCN, which many of you will, because that's the whole point that you're on this local leaders network, if you can influence that in any way and nudge the GPNs that you know have got talent and they're hiding it under a bushel, then please get in touch with us at GP Excellence. So that's my final plea for the day, and I'm 1 minute over, so I'll let you all get off now. So thank you all very much for joining us, and we'll see you again at the next session.
Thanks, Joanne.